And certainly when radiotherapy was given 30, 40 years ago is very different from today. The risk of the doses and the fields have dramatically changed over the years. The risk of second malignant neoplasms, valvular cardiotoxicity, pulmonary fibrosis, as well as bony deformities and muscular hypertrophies are not as much as they used to be. So while we are trying in Hodgkin lymphoma to reduce or eliminate radiotherapy, I don't want you to leave today thinking that radiotherapy is not your friend, because there are certainly important indications for radiotherapy. So this is a patient with Hodgkin lymphoma before starting therapy, and very often we see this PET scan after 2 cycles, and now what do we do? How do we adapt our treatment? And most of the times the protocol will be pre-described as to what to do next. In this picture, what I want to show you is that the bar that you see there appears to be darker than the background. Do you agree? Right? Appears to be darker. Now if I show you this picture, the bar clearly appears to be lighter than the background. In reality, the bar has the same color, but it is our brain compares it, everything is relative, compares it to the background. So the same happens when you read a PET scan, and therefore the interpretation of PET scans have to be done very carefully and by somebody expert in reading it. As you see, as the background gets darker, the bar appears lighter. These are the Deauville criteria, and at Deauville 1 you wouldn't see anything. On a Deauville 2 you see, let me see if I have a pointer. I don't. Yeah, it doesn't. So in a Deauville 2 you see a little bit of something, but it's less than the mediastinum, and a Deauville 3 is more than mediastinum, less than liver, and Deauville 4 is more than liver. And then a Deauville 5 would be if there are no lesions or very much more than liver. So whether you call a Deauville 1 and 2 negative and a Deauville 3 and 4 positive really depends on what you follow. Oh, there, yes. Okay. Right. Okay. Thank you. Thank you. And many protocols have actually adapted the border of what is positive to negative at a Deauville 3. So it is very important when following a particular regimen to check what is described in that particular protocol as positive and negative. So I'm going to talk a little bit starting about the low-risk trials, and I'm going to concentrate on pediatric trials only. This is a pediatric trial from St.Jude, in which only patients with very low risk, stages 1A, 2A, no mediastinal bulk, and less than 3 sites of disease were enrolled. For this protocol, peripheral bulk was not an indication not to be enrolled. So they got 2 cycles of VAM, response evaluation, and then 2 more cycles of VAM. And if at the response evaluation they were in CR, that they finished, and if they were in less than CR, they got involved field radiotherapy. CR was defined as more than 75% reduction of disease by CT scan and a negative gallium or PET scan. Now, one of the problems with this protocol is that it has 200 milligrams of anthracycline. So to give 200 milligrams of anthracycline to a patient that is low risk is probably not something that I would suggest to do today. And when we look at the survival curves, they're pretty good, with an event-free survival of almost 90% and an overall survival of 100%. And as you can see here on the right, there is no difference for patients that did or did not get radiotherapy, but only 38% of the patients did not receive radiotherapy, and that was likely due to the fact that the response criteria was so strict. So not only PET negative, and at that time we considered PET negative Deauville 1 and 2, but also the anatomic response had to be at least 75%. When you look at the German study, the GPOH 2002 for stage 1 and 2A, they received 2 cycles of OPA or OIPA, and then response evaluation, if they were in CR, that was it, and if they were in less than CR, they got 19.8 gray. Here, the CR definition was very strict as well, a volume reduction of 95% by CT scan. They did not have PET scan, and the anthracycline dose is 160 milligrams per meter square. So 95% sounds so much more strict than the 75% in our previous study. However, when you do a volume reduction calculation and you do it in 3 dimensions, it is sort of it does correspond to about 75 to 80% reduction in a 2-dimensional reading. So it's not that much different than on the BANK study. And here you see, oh, I'm sorry, I'm going the wrong way. And here you see that they did very well. The low-risk patients, EFS of 92%, and an overall survival of 99% for this low-risk group, and about 49% of the patients did not get radiation in this trial. The Euronet C1 trial continues with the OIPA. Now nobody gets OPA, and the response evaluation, they define an adequate and an inadequate response. And here the volume reduction, as you see, is much more liberal, to only 50% by CT scan, and it needs to be PET negative. And again, 160 milligrams per meter square of anthracycline. And you see that here, regardless of treatment arm, whether you are low risk, intermediate, or high risk, the event-free survival is excellent, and it's superimposable. And 66% of TG1 of the low risk patients did not get radiation. So that's pretty good, much better. And again, this because they changed the response criteria. In the meanwhile, Children's Oncology Group had their AHOD 0431 study for the stage 1A, 2A with no mediastinal bulk and no peripheral bulk. They gave 3 cycles of ABPC, and then response evaluation to stop or to give 21 gray radiation. The CR was 80% reduction by CT scan, and the PET and gallium should be negative. At the beginning of the trial, this was not quite so. The definition of CR was changed during the trial, and the anthracycline exposure was of 150 milligrams. In this study, patients that were in CR, if you remember, don't get radiation, and 78% of the patients did not get, were in CR, and 83% were in PR. At the end of the day, only 63% did not get radiation, and the reason is because because they changed the criteria halfway through the trial, that patients that had PET positive after 1 cycle had to come back to get radiation. So it was a little bit of a messy trial, but still the event-free survival was 80%, and the overall survival almost 100%. For intermediate risk patients in the Children's Oncology Group in the AHOD 0031, stages 1A, 2A with bulk, 1B, 2B, 3A, and 4A. So it's a very large trial with a lot of patients. It really encompasses a very diverse population of patients. They started with 2 ABV PC, and then they looked if you were a rapid early responder, you continued with 2 more cycles, and then you were randomized if you were in CR to either stop or to get 21 gray radiation. If you were a slow early responder, you got 2 ABV EPC, then, or you could get 2 DECA plus 2 ABV EPC. So it was an intensification with this DECA, and they all got radiation. In this trial, every site that was bulky also had to get radiation. Rapid early response was at least a 60% reduction by CT scan, at the early response evaluation, and CR, so that's where determined whether you were randomized or not, was the 80% reduction by CT scan and a negative PET or gallium. And here you have an exposure of 200 milligrams per meter square of anthracyclines. And what the results show is that the 4-year event-free survival, whether you got radiation or not, was the same, 88 and 84%. And the 4-year event-free survival for stages 1 and 2 was pretty good at 91% for stage 1 and 84% for stage 2. And 44% of the patients did not get radiation in this trial. The problem with this trial is that patients with stage 4A did not do so well, but that's a different story. So in these studies, what we can conclude is that the overall survival is close to 100% regardless of what you do. The event-free survival is between 80 and 90%, and no initial RT was given in anywhere between 40 and 66% of the patients. So if you want to choose a study by how many got the least radiation, probably what you would go by would be the 2 cycles of OEPA in your low-risk arm. What about intermediate and high-risk trials? Oops, sorry, this is again the Hodgkin one that I already presented. I don't know how this got. The only thing here on the Hodgkin study that I had just presented is that the addition of DECA, the intensification, did not add anything to the event-free survival. So whether you got DECA or not, there was no difference, except for patients that were PET positive initially, and those patients that got DECA seem to have done a little better. However, there weren't many patients, and the p-value is only 0.05, so it's not even enough to make it a recommendation, and I would not follow that route necessarily. The next high-risk study for the COG was the A31 for stages 3B and 4B. So this is a very high-risk study. And here they divide into rapid early responders. They got 2 additional ABV EPCs, and they got risk-adapted RT only to 21 grade to bulky sites. And then if you were a slow early responder, you got an intensification as well with ifosfamide vinorelbine as well as ABV EPC, and radiation to bulky sites and to PIT2 positive sites. So any site that was positive at PIT2. It was not an involved field radiation trial. It was, so not everybody, not every site of disease or at original diagnosis was irradiated. Here, CR was defined as complete disappearance of all detectable clinical evidence of disease and disease-related symptoms if they were present before therapy, and the PET had to be negative. And the rapid early responders were PET negative, here defined as Deauville 1 and 2 only, irrespective of the size of the residual mass on CT. So what we can see is that in this trial, the 5-year first event-free survival rate for rapid early responders and slow early responders was 84% and 73%. The overall survival was close to 90%. But then the aim of this trial is to have a second event-free survival of 95% or higher. It means that from your whole cohort, how many patients do not have a second relapse? So it's an interesting design for a study, but unfortunately they did not achieve it. As you see, the 4-year second event-free survival was 92% only, and they wanted 95%, which was very ambitious. And just for completeness, I want to show this study that was done also by before the Children's Oncology group was formed by the CCG and the POG. This was CCG trial, where high-risk patients, 2B, 3B with bulk disease as well as stage 4, were given a sex-adapted treatment. So you can see that you get 4 cycles of escalated VIA-COP and rapid early responders. If you were a female, you got COP-ABV, 4 more cycles. If you were a boy, you got 2 cycles of ABVD plus radiation. And if you were a slow early responder, everybody got 4 more cycles of escalated VIA-COP and then involved field radiation. I hope nobody would be doing this study today anymore. Yes, the event-free survival is 94%, but it is extremely toxic. All the boys are infertile with this therapy, and even half the girls will probably be as well. And there were very few failures, but also, if you did, for those that did relapse, they were not salvageable after such an intense therapy. And currently, there is the Apoc 1331 study, where patients are randomized to receive either the standard arm, which is 2 cycles of ABVEPC, and then if they were, then they get an assessment, and then they get 3 more cycles of ABVEPC, and they get radiation only to the sites that do not have an adequate response, or they get the experimental arm, which is 2 cycles of brentuximab vedotin with ABEPC, so they remove the bleomycin because it's toxic together with brentuximab vedotin, and then the same. They do a response evaluation, 3 more cycles of the same, and they only get radiation to the sites that are not rapid early responders. And this study has not been evaluated yet and is still ongoing. Whilst in the Uranet C1 study has closed. As you see, patients in TG1 I presented earlier got only 2 cycles of AIPA. If you were intermediate risk, you got 2 cycles of COP or 2 cycles of COP-DAC. And if you were a high risk, 4 cycles of COP or 4 cycles of COP-DAC. So, and this is to eliminate the procarbazine in the COP that is sterilizing, particularly for boys. And then the radiation. In this trial is an all or nothing. Either you had a complete response in all sites and then no site gets radiation, or you had an inadequate response even only at one site and still all sites got radiation. So it's an all or nothing. It was an all or nothing trial, but you see the results are excellent with no radiation or radiation being superimposable, and there was no loss by eliminating radiation. But this was a very strict criteria, again, as you see, because there was no reduction in the volumes of radiation. And currently there is the Uranet C2 trial where they are having a standard arm with 2 cycles of AIPA and either 2 or 4 cycles of COP-DAC for the intermediate and high risk. And so only intermediate and high risk get randomized to either 2 or 4. If you're intermediate risk, you get 2. If you're high risk, you get 4 of COP-DAC or decop-DAC. So they get an intensification with dexamethasone, dexamethasone and etoposide and doxorubicin. And these patients, then the ones in the decop-DAC arm get only radiation to the sites if they are slow early responders or inadequate responders to the sites that are not NCR at the end of all treatment, versus the standard arm gets radiation according to their early response evaluation. And here you can see the risk stratification, and normally I like to put in a table about risk stratifications because it really is so protocol dependent. You cannot say unanimously that 2A is always low risk or that it's always intermediate risk. Depending on which trial you're looking at, it could be low risk or it could be intermediate risk. And so it is very important that you risk classify your patient according to the regimen that you're planning to use and not cross stratifying. And this is what we have been doing at St.Jude for the high-risk patients. We gave 2 cycles of AIPA, so we took out the vincristine and are given brentuximab vedotin instead, do a response evaluation, and then they get either 4 cycles of Capdac with radiation or 4 cycles of Capdac without radiation according to the response. But in this trial, we do not irradiate sites, so we only irradiate sites that have an inadequate response of early response evaluation, meaning that most of our patients that get radiation get only like a teeny tiny little bit of radiation, as opposed to the original C1 trial where when they got radiation everywhere. So in this trial still 66% of the patients did get radiation, but again, they only got radiation to very small sizes. And now we have, in our newest trial, we have changed the response criteria to be just PET-based. When we first started, it was CT and PET-based, so it was stricter. Now we're hoping that it's going to be closer to maybe 55 to 60% of the patients that get radiation instead of 66. It's still a significant number, but again, if you compare it to trials 10 years ago where every single site gets radiation, it is much less. And if that little radiation will prevent them from relapsing, then I think it's worth it. Of our 77 patients that were initially enrolled in this trial, and the trial has this particular trial closed 2 years ago, we had only one treatment failure, and that patient was salvaged and is in remission after an autologous stem cell transplant. So it seems worth it. So going back to everything is relative, if I ask you to tell me which one is darker, A or B, turns out that they are the same color, but because of how you put it, they look the same. So with this, I am ready for my conclusions that most patients with Hodgkin lymphoma can be cured with chemotherapy alone. Chemotherapy alone combinations have to be given beyond CR and often contain higher doses of alkylators and anthracyclines. Chemotherapy alone combinations harbor high potential for significant toxicity and late effects that need to be considered, though the modern therapies are actually quite good. And a refined staging and response assessment strategy improves tailoring of therapy. So a response-based approach is certainly the way to go. But in a setting where refined and sensitive imaging modalities are lacking, some patients will be overtreated and some patients will be undertreated, and we need to be aware of that. I want to finish inviting you to the 4th International Symposium on Childhood, Adolescent, and Young Adult Hodgkin Lymphoma that is hosted by Professor Maud Kerholz and myself in Berlin in May of this year, and that's the website if you want to register. And thank you very much. I'm happy to answer any questions.
Okay, for any questions from the audience? If not, I want to ask a question. We are following the C1 here. So, not to give radiotherapy, and we have a higher proportion of our patients relapsing, then we get them into remission again by the second line IEP with the ABVD and then radiotherapy. Versus to give the radiotherapy up front and then having most of your patients not relapsing if we are using another protocol rather than the C1.
Oh.
So what would you advise us to follow which pathway?
So I would first review if your patients are relapsing because they may not be getting the intensity of the dose. I mean, are you making sure that, like for instance, I know that the OIPA COPDAC is to be given every 4 weeks the OIPAs and then every 4 weeks the COPDACs. I don't do 4 weeks, I do 3 weeks between one COPDAC and the next. So I wonder if intensifying your chemotherapy first would be the first way to go. but you can do an analysis like the COG did and see what is your second event-free survival. So what is your likelihood of relapse and in which population it is to understand who is at risk for relapse. And check if maybe the bulky patients that end up in CR that are the ones that are relapsing because they didn't get radiation, and then I would only radiate the bulky side. So I think you need to look at the data a little bit, and I wouldn't immediately jump into giving everybody radiation.
I have a question. I have a question, if I may. Is this on? Yes. It's working. Yes. Could you bring back the slide? Could you bring back the slide that had the conclusions? Yes. Now, throughout the whole presentation, there were cases, the ones who were advanced, and those who did not respond. You gave radiotherapy.
Yes.
Here you don't mention radiotherapy at all. Where?
You're right. You're right. I should have because radiotherapy is important.
Yes.
And
When?
And it is important when you don't get an adequate response.
Yes.
And maybe it is important when you have bulky disease, but we don't know that. I know in one of, for instance, the COG study with the second event-free survival, this one. So they gave radiation. They give radiation only to bulky sites. Now I wanted to look at. I mean, still,
Yes,
it would be
but
interesting to see where they relapsed.
Okay. In the title of the paper is the role of radiation, or do we need it or we don't need it? And now you have the conclusions.
Yes.
You didn't mention radiation at all.
I'm sorry.
So could you, in a nutshell,
Yes.
give us a 1, 2, 3 for radiation?
Yes.
Thank you.
Thank you. Thank you. So radiation should be given to sites that have an inadequate response. And radiation should be given following the guidelines that you're following. So you shouldn't just make up where you want to give radiation by any patient. Unfortunately, very often what happens is that every patient presents, it's like a new revelation. Oh, what do we do with this patient? Do we give radiation or not? When there are very clear guidelines on whether you need radiation or not in your protocol, depending on what you're following. For instance, if you're following the Euronet C1, the Euronet C1 says that if you have one site that is inadequate, you give radiation to all the sites. If you are following, for instance, my protocol from St.Jude, just to say, where we do not give radiation to every site, I would not want to see that you are giving radiation to every site. So you shouldn't be matching and mixing, because it's not a chessboard game where you just, or a puzzle where you just use the pieces that you like. You really have to stick. If you want to have the same results, you have to stick to the same recipe, right? So if I have a recipe for a lemon pie and a recipe for a chocolate tart, I cannot have the ingredients of one and follow the instructions of the other and expect to get the lemon pie. So, yes.
Monika, I would just want to add on this discussion another aspect. I hear from several colleagues in the Middle East that they feel that the Hodgkin's disease here in this region is much more aggressive or not responsive to chemo than the one we described in the Western world. So to support what you're saying about studying the data, and I know that you are consulting around the world, not that you know the answer, but do you have a hint whether is this correct, that the biology is different, or is it what you were mentioning, that maybe the way the chemo is applied and this need to be first addressed before we go to the question about radiation and the rest?
So I don't know, and that's a good question. I haven't seen anything to suggest that the biology is different, but I think it's because nobody has looked either. I think the only thing that we know is that there's this differences in EBV in the Hodgkin lymphoma. So for instance, in Latin America, the Hodgkin tends to be more EBV positive than, for instance, in the US or in Europe. However, the Americans claim that being EBV positive makes it less aggressive, not more aggressive. So I think it may have to do with the latency of presentation, with the large bulks that present sometimes. But I have patients with large bulks coming to me too. So I think it would be interesting to see, but I think first we have to clarify, you know, how is the chemotherapy applied, how is the radiation applied before anymore.
If there's no more questions, thank you, Monika.
There's one here.
One more? Okay.
Yes, my name is Yusuf Madani from National Cancer Institute. I wanted to ask you about two questions. The first question is about nodular lymphocyte predominance Hodgkin lymphoma, about the early stage and advanced stage, and the St.Jude experience of nodular lymphocytes. The second question is about ataxia telangiectasia with Hodgkin lymphoma, your management and your protocol.
So the first question was about nodular lymphocyte predominant Hodgkin lymphoma, about surgical excision alone, right? So after it sort of became more of more interest after the publication that came from the European group, where they reported on 50 cases that excision alone was an alternative to giving chemotherapy and radiotherapy, and even though it had been done before, so there's a case series, you can follow it. In any case, what I can tell you is that we observe patients that have where we can do excision alone, and I have observed patients where I have excised twice, and it all depends on what the family prefers. So in that case, because it's so indolent, I would go by what the family's choices are and give the alternatives. I have had a patient, for instance, with a completely excised little lymphocyte predominant, where I told the family, he's cured, we don't need to do anything, where mom was so freaked out, she absolutely wanted chemotherapy. So I gave him low-risk chemotherapy against of what I would have really wanted to do, and she's like, no, she wouldn't be able to live for the rest of her life if her son didn't get chemotherapy to cure the cured disease. And maybe today I would be much more aggressive in not allowing this, but this was 10 years ago, where it was, you know, at the beginning when we were starting not to do it. Whether they are more at risk for transformation into non-Hodgkin lymphoma, there is no data, nobody knows. And so in a nutshell, I observe, if it comes back, I give low chemo like CVP. If it is bulky, CVP does not work, I wouldn't do it. I would give a VPC, which is a little bit more intense from the COG. And if it is a stage 2A, like let's say bilateral cervical and axilla, then I would go for 2-OIPA. Would I give rituximab? No, I wouldn't. Why would I not give rituximab? Because already without rituximab, 90% are cured. So maybe you increase 2% or 3% the chances of relapse, but you're putting all these other kids at risk for the side effects of rituximab. So I don't do it unless a patient comes with disseminated disease, which I have seen in LP Hodgkin lymphoma with bone metastasis and liver and spleen. Then I would give rituximab. In regards to the ataxia telangiectasia, those are very complicated cases. There are very few that survive just because they don't tolerate the doxorubicin, they don't tolerate the etoposide, they don't tolerate radiation. So it's very challenging. We had a protocol at St.Jude and they got VAMP and COP with a modified doxorubicin dose. But there are some publications out there, but I don't have much more experience on that. Thank you.
Thank you, Monika. I'd like now to present my friend and colleague,